the Democratic Republic of Congo has declared its first Ebola outbreak in 3 years. I mean, this is a worrying thing. It's since early September in the Kasai province near Bulake. At least 48 confirmed and probable cases of Ebola have been reported, with 31 deaths already, according to the World Health Organization. Health workers are scrambling. Over 900 contacts of infected persons are being traced. Vaccination campaigns have begun. Essential supplies are being flown in, and treatment centers are being set up. It reminds you of, well, what year was that again? All over again.
Yes.
This outbreak is far from Nigeria, but it raises urgent questions for us here. How vulnerable are Nigerians' land and air borders to spill over if anything was to happen? Is our health surveillance strong enough to detect early cases? Or do our health workers and facilities have enough capacity, PPE, isolation wards, and vaccine, cold chain logistics? Are our ports of entry screening good? These aren't hypothetical queries. They have real implications for lives, the economy, and also public confidence.
And this is not the first time West or Central Africa has grappled with Ebola threats. The DRC has seen 15 prior outbreaks since the 1970s, showing both advances in response and recurring challenges in remote areas with rough terrain. Past outbreaks have revealed systemic issues, delays in detection, poor infrastructure in rural health zones, weak community awareness, and challenges in contact tracing and vaccine development or deployment. In Nigeria, during the 2014 Ebola outbreak, swift border screening, community engagement, and emergency operations helped avert wider spread. Yet since then, funding, training, emergency planning, and disease surveillance have waxed and waned. With frequent travel between Nigeria and DRC, porous borders, and informal crossings, any gap in our system could prove costly.
We had to do all that because you need to know how important this is.
Right.
Now, let's welcome Dr. Alero Roberts, public health specialist, to help us explore Nigeria's preparedness, the gaps, and what must be done now. And also we have Aimé Zonveni, editor-in-chief, Kinshasa Times, will be joining us as well to have this conversation.
Good morning.
You're welcome. Thank you very much for joining us, Dr. Alero. Good to have you here. I'd like us to start with what you think the situation, or how you think the situation in the DRC might be a problem for us here in Nigeria. Let's know exactly why we should be at alert.
Concerned about what is going on in the DRC, because we do know from past experience, and the year was 2014, by the way, that international travel is the main reason why the Ebola virus disease got into Nigeria in the first place. I've actually been looking it up to find out whether the Ebola virus, the virus that causes the disease, somehow, exists within Nigeria, but there have been no documented report in any of the websites that I checked to know whether it's actually native to Nigeria, so to speak. So our biggest threat will be through international travel. And that's why you will find out that on the 6th of September, the NCDC issued a public health advisory telling people, be on alert, these are the symptoms to look out for, this is where not to go. If anybody has had any contact with anybody from these areas, this is what to do.
Okay, so Dr. Alero, my question now would be, most times when we see these outbreaks, they always come in different forms, and, they just appear. Sometimes it's, more tragic, sometimes it's less. What earlier warning signs should Nigerians be watching out for, considering our proximity and movement of people across borders?
I think the most important thing for people to realize, and this is something that we keep teaching over and over again, not every fever is malaria, number one. So if anybody has a fever, aches and pains, neck pains, please go to the nearest accredited health facility for proper screening and assessment and treatment. So these are the things to look out for. There's what we call the dry symptoms, the headache, nasal congestion, discomfort, aches and pains in the joints. Anybody, a fever, of course, anybody having any of those symptoms. And then we have to remember that these are very generalized symptoms. And most often, we just most people just assume that, oh, it's malaria, this is what malaria feels like in my body, and then goes to a chemist, buys some anti-malarials and thinks that it's all over. No, it is not. We have to realize that we have to push out that message to the public. Not every fever is malaria. In fact, we are seeing fewer and fewer malaria cases compared to the number of fever cases that we have. Lagos State put out a data point that less than 1% of fevers that they tested were positive for malaria, which means that over 98% of the fevers were not malaria. They could have been something else, and it could have been Ebola. We don't know. So please, if you know of anybody who's suffering from body temperature, aches and pains, anything kind of feverish illness condition, please encourage the person very strongly to go to an accredited health facility.
Dr. Alero, thank you very much for that. I also wanted to note that there was a scare in Abuja, but it was confirmed that it wasn't Ebola. But it's good to always note that if there's anything that you're checking, that you've seen, any observations, that you should go to the hospital. Thank you for that alert. We're also now being joined by Aimé Zonveni. He's the editor-in-chief of Kinshasa Times. Mr. Zonveni, you're welcome. Thank you very much for joining us. We'd like to know what the situation is in the Kasai province of the DRC, since you're in that side of town. What is the situation like there?
Even though it's pretty much contained, even though there are still some cases arriving, but the situation is pretty much contained.
Mr. Zonveni, my apologies, but we are unable to hear you. It might be because of the device you have connected to your phone, so we are unable to hear you properly. It's not very good audio. If you can please help take away that device, I'm sure that we'll be able to get your submission properly.
Can you hear me now?
Better, yes, much better.
Now?
Thank you very much.
Is it better now?
Yes, much better, thank you.
Yeah, I was saying that Bulape, which is the city where the outbreak was first discovered, the situation there is pretty much contained now, because upon discovery of suspect cases, the cold chain was in the days that followed deployed, and frontline personnel were involved in order to contain the propagation of Ebola in other cities of the country.
So, Dr. Zonveni,
Mr.
Zonveni, pardon me if I butchered your name. So the DRC right now has faced over 15 Ebola outbreaks in the past.
Actually, this is the 16th case.
A lot. So would you say that the response now is different from the previous ones, and what challenges persist in the rural areas?
Well, the response is definitely different now, because the DRC, as you've indicated, what they indicated, is now experiencing its 16th iteration of the Ebola outbreaks. And in 2021, the DRC was able to conduct a randomized clinical trial that allowed the country to establish that 2 investigational products were now medications. These are being now used in Bulape in the Kasai, where the outbreak has happened. That's the first thing. Secondly, the DRC comes with quite a lot of experience in this disease because it has been having it for the last 16 iterations. And now, immediately upon receiving news that we had another outbreak there, samples were sent to Kinshasa and the cases were confirmed, and immediately frontline personnel were deployed, being vaccinated, and also contact tracing was happening. So the DRC has simply deployed its long experience of managing the disease.
Thank you, Zonveni. Dr. Alero, let me come back to you. And jumping off of what Zonveni has just told us regarding the DRC's experience in handling this disease, it continues to reoccur. 16 outbreaks, that's very, very interesting. I'm wondering exactly what the source is. Why does it continue to reoccur in the DRC? That's on one hand. I have another question regarding logistics of this all and when it comes to border control, but why is there the reoccurrence each time?
I think the best person to answer that question will be the virologists and the zoologists, because this is a zoonotic disease, which means that the virus is common, is endogenous in the animal population. We're not even sure which animal it is, but a lot of people have suspected all kinds of bushmeat sources. It's when it crosses over into the human population that it becomes a problem. So you can see from this picture that they're showing that that juxtaposition of human beings in a very bushy, highly vegetated area means that there can be easy transmission if you eat or come in contact with an animal that has the Ebola virus in it. And the Ebola virus may not necessarily be dangerous to the animal, but of course it's very dangerous to the human being. So, but the zoologists and the virologists are in a better position to give accurate information on that. I'm just speaking as a public health physician.
Oh, well, thank you very much.
And that is why the last time too we had that public health advisory that people should stay away from animals. They're not sure how they died. They're not properly, treated and cooked, and just stay away and be safe.
Okay. Thank you very much. Zonveni also told that in the DRC they've employed the long arm of experience when it comes to tackling this disease. Now they're ready, it would seem, but we here in Nigeria, we have some of the biggest entry points in Africa, if not the biggest entry point in Africa. We expect people from all across Africa. So how prepared would you say Nigeria is this 16th breakout in the DRC, where we still have very questionable border controls when it comes to these matters? I had a couple of experiences during the last outbreak at the airports, and it made me wonder if we are absolutely, truly prepared. How prepared do you think Nigeria is?
To be honest with you, we've got a lot of experience regarding this. And I don't say this lightly because I'm not a government spokesperson, even if I'm a government worker. But to be honest with you, polio, we must never, never, never underestimate the efforts we put in to contain polio at the time. And all that training goes towards disease eradication, whatever the disease may be. In 2014, when Ebola finally hit our shores and we had all that tragic outbreak, all the country had to do was deploy the polio team to Ebola, and everything that they had in place to monitor, surveil, and eradicate polio, eliminate polio, was simply deployed to yet another disease. As it was, how we described it was, copy and paste, find polio, remove it, put Ebola in place, and the strategies, the processes, that was what we employed. It has remained in place because we've had an ongoing outbreak of Lassa fever. We've had spotty outbreaks of other viral hemorrhagic fevers. We're still monitoring and maintaining our polio status so that we can get to the final lap. And so those are the things that we've simply had in place. However, and I know that's the next question you're going to ask, so can I just preempt that?
Go ahead.
The question is, have we sustained this? So when you're talking about, say, the border control processes, don't forget, Nigeria has over 4,000 kilometers of land border with 4 countries, Benin, Niger, Chad, Cameroon, plus over almost 1,000 kilometers of coastal border in the Gulf of Guinea. How can we monitor this? Needless to say, it cannot be monitored, and it should not even be monitored. It's a waste of personnel and resources. But it means that when you think of the number of villages and settlements that are near the border, think of Seme all around the country, think of Chikanda in Ilorin, Kwara State, think of Babana. These are areas where the villagers or the people in the settlements are crossing from left to right. They are going to their neighbor's house. It's a different country. So these are the things that make it difficult to say border control. What we can do and what we are doing very effectively, and we've been doing it since COVID. The last time I traveled every time we come into the country, we are made to fill that form, that disease screening form. And that's what the NCDC has had in place. We have had these protocols in place. And we just need to make sure that they are strengthened, they are ongoing. But we have to also take personal responsibility when it comes to this, to make sure that we listen to the public health advisories and put them in place for ourselves as individuals.
Thank you so much for that, Dr. Alero. So, Mr. Zonveni, I think I used Dr. Alero for you the earlier time, I beg your pardon. So reports suggest that, vaccination campaigns have already begun in Kasai. Can you tell us how effective has the deployment been so far, and is the vaccine access equitable?
To require logistics, especially in terms of cold chain, because these vaccines have to be deployed in a temperature-controlled environment. So the DRC, which is a very large country of 2 time zones, the vaccines are in Kinshasa, which is the capital. But now, as I speak, after 5 to 10 days of preparing the logistics of deploying the vaccines, they finally reached Mulape, where the outbreak has happened. And now we have noticed a stark improvement. Pretty much anybody coming now, and they start with the frontline personnel, those that are like the nurses that are in immediate contact with the disease. Those are the ones that are first vaccinated. They call it ring vaccination. And then contact tracing happens whenever there are symptoms that are identified, immediately samples are collected and are sent to Kinshasa for checks. But I can tell you the vaccines strategy is now in full implementation and is delivering results.
Zonveni, could you also tell us about the containment, the areas that are affected? How, should I use the word secure? Is it how separate is it or segregated is it from mass population?
In fact, the disease, as I've indicated, has occurred in a place called Bulape. Bulape is in a place in the DRC, in the province known as Kasai, maybe not the name, but what should be mentioned about this part of the DRC is that it is fully landlocked with no immediate international borders nearby, which means the disease really stays within the DRC without the possibility of it reaching a nearby country. But of course, I think the doctor mentioned that someone could move from that location, come to the capital city, and then eventually travel. And so the potential of the disease through travel, reaching other parts of the DRC with international borders is not real. But the National Institute of Medical Research deploys personnel there to ensure that pretty much that does not happen, that people do not travel from Bulape to other parts of the country and potentially spread the disease further in the country and possibly beyond the borders of the country.
Okay, so Dr. Roberts, I wanted to ask that, so on Nigerian side, how critical is community engagement and trust building in preventing, panic and stigma? Should we, should a case emerge again, how prepared are we?
Good question. So let's take it a bit at a time. Community engagement is essential, and thank you very much for this program, and thank you very much for bringing the gentleman from DRC to give us both sides of the story. Community engagement is fundamental in the sense that what we need to do is educate the public. What we need to do is to engage the community leaders so that they also speak to their people. We need to understand what the public fear and be able to address those concerns and anxieties at a level that the public can understand. So the media is critical to this. Safe media, sensitive media reporting. I know the NCDC has engaged in a lot of training of the media to get proper health reporting out. That is absolutely critical. So, and that helps to build trust. Again, we've got to build that trust again between the public and the health facilities. Now, this works all very well in a place like Lagos, place like Port Harcourt, Abuja, but we need to be able to push it out to the more rural and underserved areas, because the issue is that if it does come, and he raised a very important point, where Kasali is a landlocked area, nothing stops anybody traveling from there to the capital city and from there out of the country. Don't forget, Ebola has an incubation period of 2 to 21 days. That means for 2 weeks, 3 weeks, the person may feel well and travel and have no problem at all, and then suddenly come down with symptoms of Ebola, and he's in another country, in another state, in another part of the country. So it's important that we continue to educate the public about the symptoms, the preventive measures, and what does not work. We don't want people drinking salt or bathing in salt water or washing themselves with bleach, please.
Thank you very much, Dr. Alero. I remember that was actually a thing. There were those concerns, people actually using some, I don't know what to call them, means to try and be safe. However, let's come back to Mr. Zonveni. Zonveni, so in 2014, the media was very responsible for getting word out, community engagement when it comes to making sure that the disease does not spread. At least here in Nigeria, we had plenty of outreach programs, whether it was on traditional media or whether it was physical engagement with communities. Now, I'm wondering what the situation is like in Kasai, what the situation is like in the DRC. How involved is the media in getting the message out? And are people aware of what to do ordinarily, noting that this is the 16th outbreak? Do they know how to conduct themselves in these situations?
Of course, in the National Institute of Medical Research, they have a whole social mobilization and communication department whose role is, whenever there is an outbreak, and this is part of disease preparedness, their role is to go to where the disease is occurring and engage with the masses, giving them advice on the right behavior to demonstrate. Now, when it comes to Ebola, in the DRC more specifically, emphasis is put on the fact that the moment you notice symptoms such as fever, such as throwing up, and all these other symptoms that are quite similar to other disease, get to the treatment point or to the hospital and get tested to know whether this is Ebola or a different disease. The other aspect, which is maybe specific to the DRC, is that now that the country was able to conduct that trial, and we have 2 medications that are effective against Ebola, but these medications are only effective if you get to the treatment center as early as possible. Beyond a certain date, it becomes impossible for these medications to work. So in part, amongst the advice given to the people here is that whenever you start feeling those signs, get to the hospital at the earliest, so that if it is Ebola, then the medication is known as Inmaz and Ibanga that are now FDA approved in the US and are available in the DRC, actually are being used in this outbreak. If you get to the treatment center early, chances of survival are quite high. But if you get late, when you are already hemorrhaging, it is difficult to recover from this. So it's really part of the communication which is given to the masses. Now, how is it given? In the cities where we have internet, where we have online media, this goes through our mass media. In the villages, what we tend to use is community radio stations, because these are spreading wide across the country, and they have a wider reach. And also, the DRC is a country with 250 different ethnic groups and 400 languages. So we try and channel these messages in the various languages the country has, but mostly in the 4 national languages that are understood pretty much across the country.
Thank you so much, Mr. Zonveni and Dr. Alero Roberts, for joining us this morning and bringing this on the ground perspective. Thank you so much.
Thank you very much.